So the CARTITUDE-2 trial is a study of cilta-cel in a number of different cohorts of myeloma patients, particularly with unmet needs. And cohort C was looking at patients who were refractory to a proteasome inhibitor, IMiD, CD38 antibody, and had had a prior BCMA-directed therapy, specifically an antibody-drug conjugate or a prior bispecific. Patients who had a prior BCMA CAR were not allowed in that cohort. So the cohort enrolled 20 total patients who ended up successfully manufacturing and getting their CAR T cells. 13 had had a prior ADC, 7 had had a prior bispecific antibody. These were a very heavily pretreated population, median of 8 prior lines of therapy. Almost all were triple-class refractory, most were penta-refractory, and 80% were refractory to that prior BCMA therapy. And so more heavily pretreated than even the CARTITUDE-1 study. And the main findings were that about 60% of patients overall did respond to cilta-cel in that setting, so lower than what we had seen in a BCMA-naive population, but still a very robust response rate in this heavily pretreated population. The durability of those responses, though, seemed a little shorter than what was seen in CARTITUDE-1, so a median of about 11 months duration of response, and a median PFS ranging between 6 months for the prior bispecific antibody treatment and roughly 9 months for the prior ADC treatment. The safety profile seems fairly similar in this BCMA-treated population compared to the BCMA-naive population. So I think overall it shows that you certainly can give cilta-cel or a BCMA CAR product after a prior non-cellular BCMA-directed therapy, and that you can get responses in roughly 60% of patients. But it still remains to be seen what the optimal sequencing is going to be and if that's really the best place to use this or not. I think we need to enroll, larger numbers of patients before we can draw any firm conclusions.